Welcome to our lecture content over drug therapy for anxiety and insomnia. Make sure to review your objectives for exam purposes. Let's start by talking about anxiety. Anxiety is caused by the perception of potential or actual danger that threatens a person's security. With mild anxiety, it is considered a state of heightened awareness of one's surrounding, and it is seen in response to day-to-day circumstances. However, when responses to stressful situations are abnormal or irrational, or when there is impairment of normal daily function, then a patient is considered to have an anxiety disorder. When anxiety takes over control and the individual is not able to cope and or function in their normal environment, medications can help. Now let's briefly talk about insomnia. Insomnia is the most common sleep disorder known. 95% of all adults experience insomnia at least once during their life. It is a prolonged difficulty in going to sleep or staying asleep long enough to feel rested. Occasionally, sleeplessness is a normal response to many stimuli and is not usually harmful. Insomnia is said to be chronic when it lasts longer than a month. It is not a disease, but rather a symptom of physical and mental stress. We're going to begin talking about the drug class of benzodiazepines. These drugs are useful in the short-term treatment of symptoms of acute anxiety in response to stressful situations. The key word here is short-term. Antidepressants are preferred as first-line drugs for long-term treatment of most chronic anxiety disorders. This drug class has a wide safety margin between the therapeutic and lethal doses. The drugs within this class are administered for a variety of reasons because while they all have similar actions, individual drugs within this class act more selectively at specific sites. Benzodiazepines are also commonly used because they are less likely to interact with other drugs and less likely to cause overdose. Benzodiazepines are a Schedule IV drug. They may cause physiological dependence, and therefore withdrawal symptoms can occur if they are stopped abruptly. It is necessary to taper the patient off these drugs before completely discontinuing them. Benzodiazepines were introduced in the 1950s and remain popular today. Benzodiazepines are safer than the general CNS depressants and have a lower potential for abuse. Here are prototypes that we'll be talking specifically about. Some general pharmacokinetics is that they are well absorbed in the GI tract, and they undergo extensive metabolic alterations in the liver. When used for sleep, patients experience deep and refreshing sleep. However, there is less REM sleep involved. Usually these are given for short courses, no more than 4 weeks. As an anti-anxiety, patients generally respond to therapy within 1 week. In patients with reduced hepatic function or older adults, lorazepam is most appropriate because of the relatively short duration of action. That was weird. I'm sorry if
That was
it got
weird.
interrupted.
I'm sorry if
it got interrupted.
shut down on me.
Shut down on me. Hang on. Okay. Adverse effects. These are mostly related to central nervous system depression effects. Adverse effects are listed here for you. There is a black box warning for the combined use of benzodiazepines and opioid analgesics. Serious adverse reactions from this combination include slowed or difficult breathing and death. Other common adverse effects that patients have listed are a decreased level of alertness and the feeling of a morning hangover. With the cardiovascular system, transient hypotension can occur, so the patient should rise slowly and slowly change positions. On this PowerPoint, it also talks about the signs of overdose that are listed for you. The antidote, which competes with the benzodiazepine receptor, is flumazenil. It is given IV over 30 seconds, and it may be repeated every minute as needed. With each subsequent dose, there is a mild increase. Contraindications are listed here. For the severe respiratory disorders, they're talking like COPD or sleep apnea. And again, the black box warning for concurrent use with other CNS depressants like our opioid analgesics. Nursing considerations. Mental alertness. People who work around machinery or perform other duties for which mental alertness is necessary should not take these drugs while they're working. This includes driving. Interaction-wise, remember to keep that black box warning in the back of your mind. Assess for therapeutic effects. As far as patient teaching, it should include not to chew tablets. Do not abruptly withdraw the medication. If it's given IM, make sure it is given in a large muscle and slowly inject. If it is available in IV form, can be given IV push. Non-benzodiazepines. These drugs cause CNS depression. All of these drugs have somewhat variable effects on REM sleep. Non-benzodiazepines are used for insomnia, but they are not indicated for the occasional sleeplessness. The goal is to relieve anxiety or sleeplessness without permitting sensory perception, responsiveness, or alertness. Here are our prototypes: sulpidium and escopicolone. Let's talk about each one of these individually because their therapeutic action is a little different, but they are both used to promote sleep. Sulpidium binds to different GABA receptors in the central nervous system as compared to the benzodiazepines. This drug has less effect on sleep stages 3 and 4 and REM sleep. Daytime drowsiness is generally not a problem because of the short half-life. Helps people get to sleep and prolong sleep duration without causing a morning hangover. Period of use is recommended for 7 to 10 days, and the healthcare provider should reevaluate if use exceeds 2 to 3 weeks. S-zapaclone has a hypnotic effect due to its interaction with GABA receptors. Onset is rapid, and specifically with this one, it should be taken immediately prior to bedtime. This medication can be used for long-term therapy. It is also more effective for patients who wake up during the night or early morning. The drawback to this is that it has been reported to cause morning hangover, especially in the elderly population. It should not be taken with alcohol or other CNS depressants, as it will cause an additive effect to the medication. Both of these drugs are Schedule IV drugs. Adverse effects are listed here. Restlessness may occur before falling asleep and is usually mild. Therefore, it does not warrant discontinuing the medication. Encourage the patient to try to relax and to let the sedative effect take over. Anterograde amnesia is possible with both of our non-benzodiazepine prototypes, and this means short-term memory loss. I had a friend that I think was on the zolpidem and actually experienced anterograde amnesia. She got up in the middle of the night, started warming up some food, left it safely, thank goodness, and then found herself waking up on the couch the next morning and not remembering any of it. Contraindications are allergy, alcohol, and other CNS depressants. And caution is listed below. Nursing considerations. This I did not know. They should not be taken after a fatty meal because the fatty meal will delay the onset of the medication. Definitely they should be stored out of reach of children. And as always, before turning to medications, patients should try using non-drug measurements first. And if patient experiences adverse effects, they should be contacting their healthcare provider. This is the end of our PowerPoint on drug therapy for anxiety and insomnia.